Case 8. 2018. A 55 years old woman with shock and labile blood pressure. Definition. A 55 years old woman was transferred to the hospital for evaluation and treatment of cardiogenic shock. Approximately 4 months before presentation, the patient was admitted to a hospital in her home state for pounding in her chest, nausea, and diaphoria that persisted for 40 minutes after a routine jog. The heart rate was 65 beats per minute and the blood pressure was 138.72 millimeters of mercury. The remainder of the examination was normal.
Dealing with a patient that has an adrenal tumor requires a multidisciplinary approach, and that's really what we pride ourselves on here at the NYU Langone Medical Center. I had a lifelong interest and specialty in treating diseases of the adrenal gland in a minimally invasive fashion. We have endocrinologists, we have nephrologists, we have radiologists, and of course we have the surgeons to go along with this, and the pathologists. And the combination of this team allows us to focus exactly on what the disease is, how it should be taken out, and what are the subsequent downsides or upsides to the surgery, and how we would treat the patient in the postoperative period. Instead of making one big incision, we make a bunch of small keyholes. One of the keyholes is about 11 millimeters, a little less than half an inch, and we put a camera in there, in that keyhole, into the abdomen. The optics and the high definition are such, it's like 10-fold magnification, that we can see better with this camera than we can see with the naked eye. So the ability to have that kind of visualization and the instrumentation that goes along with that. So we make a couple of other small puncture sites, which are anywhere between 2 millimeters and 5 millimeters, that allow us to use instrumentation. And using this instrumentation, we do the whole operation identical to the way it was done in the open era. However, we do this now through extremely small holes. Patients really have much less pain in the postoperative period, and as they have less pain, they recover quickly, and they can go home much earlier.
Application in medicine. Although we typically will not proceed with tumor localization without a confirmatory biochemical diagnosis, we had high clinical suspicion for a diagnosis of pheochromocytoma on the basis of the patient presentation, and we knew that confirming the diagnosis would potentially change her hospital care because she was recovering from renal failure and cardiomyopathy, and the expected degree of evaluation in the plasma or urinary fractionated metanephrine levels was unknown. We recommended proceeding with imaging studies to identify the anatomical location of presumed pheochromocytoma.
In this video, I will be sharing with you some information on the symptoms of adrenal cancer. I created other In this video, I will be sharing with you some information on the symptoms of adrenal cancer. I created other videos on the meaning of adrenal cancer, the causes of adrenal cancer, and how to treat adrenal cancer. Please, check them out. Adrenal cancer is the type of cancer that develops in the cortex of the adrenal gland. It is also called adrenal cortical carcinoma or adrenocortical cancer or carcinoma. Adrenal cancer most often is discovered when it is found accidentally on an imaging test done looking for something else. It produces hormones that cause changes such as weight gain and fluid retention, early puberty in children, or excess facial or body hair growth in women. It starts causing symptoms because it has gotten very large. Large tumors compress on other organs in the abdomen, causing pain or a feeling of fullness. Generally, adrenal cancers are much larger than adrenal adenomas. An adrenal tumor larger than 2 inches is assumed to be a cancer. Most cancers found in the adrenal gland did not start there and are not adrenal cancers. Instead, they start in other organs or tissues, and then spread through the bloodstream to the adrenal glands. For example, lung cancers, melanomas, and breast cancers often spread to the adrenals. Even when other cancers spread to the adrenals, they are still named after the place they started and are treated like other cancers that start in the same place.
Advantage and disadvantage. Advantage. Ultimately, laparoscopic adrenalectomy led to complete recovery of her left ventricular ejection fraction. On the third hospital date, tracheopharyngeal echocardiography revealed slight improvement in global ventricular function. Disadvantage. Catecholamine curiosity to plasmacitoma. The tumor was composed of nests of polygonal cells with a moderate amount of eosinophilic cytoplasms. Immunohistochemical staining showed that the tumor cells were strongly reactive for the neuroendocrine marker chromogranin A.
When I first came to the University of Colorado Hospital, I was coming for back surgery and I was having problems climbing the stairs. I went to Dr. Estes and she sent me for that MRI and that changed my life. And she literally called me as soon as she got it and said, "You need to come back for another MRI. There's a mass on your left side." Adrenal cancer didn't mean anything to me. I hadn't heard about it ever. It affected my whole life. It changed everything. After the surgery, I hadn't seen an endocrinologist, and Dr. Kieseljak Vassiliadis, she came in the next day to visit with me. Dr. Weirman came in also. She talked with Dr. Vassiliadis, and she worked together with her to make a plan for afterwards. Then I got Dr. Leong. He's basically been my oncologist the whole time, and he works with Dr. Vassiliadis and Dr. Rayburn, and they have like little meetings every Monday and talk about the plans for not only myself but other patients that they have for adrenal cancer.
The importance in making a diagnosis of adrenal cancer especially is to deal with the patient and their family, to educate them appropriately about what the data shows, but our new realization that there's a spectrum of disease of patients with adrenal cancer, and that by understanding it, being taken care of in a center where we're seeing the spectrum and we're not saying one size fits all as far as the aggressiveness of the therapy or the ultimate prognosis.
The estimate from the American Cancer Society is that there's a few hundred cases, 200 to 300 cases in the U.S. a year. They often can get very, very big before they actually are noticed, and they like to spread.
Other
Issue applied in Ecuador. The possible cause of secondary hypertension would invariably lie in the endocrine system. In the past, the discussion encompassing the term endocrine hypertension would invariably be restricted to adrenal gland. This is a study made of University of Ecuador. We have that the adrenal issues are in more than 50%.
Hi, I'm Dr. Anantraman, consultant endocrinologist at Magna Centers for Obesity, Diabetes and Endocrinology at BTM, Bangalore. How to recognize benign adrenal gland tumor symptoms? Adrenal gland tumors tend to be very small, alright, especially benign ones. Malignant ones can be really large. That's how we differentiate between benign and malignant tumors. So typically a tumor which is more than 5 or 6 centimeters in size has to be considered malignant unless otherwise proven, actually. So we need to excise the tumor, definitely. We need to go for excision. But smaller size tumors can be left alone. And very often, these benign adrenal tumors are actually recognized incidentally. Okay. So when you go for a scan for some other reason, either an abdominal pain which is unrelated to the adrenal gland, you may find out on ultrasound or on CT scan that there is a small tumor. So these are called incidentalomas. So typically a benign adrenal tumor is asymptomatic. That's what you need to keep in mind. Whatever symptom you may get may be not related to the adrenal gland tumor itself. So if at all, you need to look to see whether the adrenal tumor is in fact causing you any trouble. You need to look at few things like your blood pressure. Is your blood pressure elevated, and is it easy to control the blood pressure? Because blood pressure can be elevated even without an adrenal tumor. Most people who have high blood pressure do not have an adrenal tumor. Okay, but then is your blood pressure elevated and difficult to control? That's again another point. If it is difficult to control with multiple drugs, then the tumor could be responsible for your blood pressure. So we need to look at this carefully. And do you have features of Cushing's syndrome? The Cushing's syndrome is actually diagnosed easily by your endocrinologist by just looking at you. Alright. So if there is a good index of suspicion, we do a test known as a screening test. The usual screening test that we do is either a urinary cortisol 20.
Conclusion. Once the localization of the presumed fibromatocytoma was identified, the plan was to proceed with laparoscopic adrenal ectomy in 1 month to ensure alpha-adrenergic blockade and allow time for recovery from both catecholamine-induced cardiomyopathy and kidney injury. After the patient underwent laparoscopic adrenalectomy, she had an uneventful perioperative course. She was discharged on postoperatory day 3 while she was receiving a low dose of carvedilol, which was stopped 2 weeks postoperatively. At her follow-up visit 1 month later, she did not report any symptom of her failure. Ultimately, laparoscopic adrenalectomy led to complete recovery of her left ventricular ejection fraction.
We're finding more and more small adrenal tumors as people get more and more imaging for other reasons. Whether or not an adrenal tumor needs to be removed depends on several things. First, we ask, is it making anything? Meaning, is it making too much of any of the adrenal hormones? And that's determined by blood tests. If it is making too much of any of the hormones, then that would be a reason to have it removed. Second reason is the imaging characteristics of it, and here we're mainly concerned about, even if it's small, does it have concerning features for being a malignancy or a cancer? And then the last reason to have it removed would be if you have cancer somewhere else in your body. Often certain cancers can metastasize or travel to the adrenal glands, and sometimes we remove the adrenal gland for that reason.